Thank you for the opportunity to share some of my research and thoughts in the area of competence with all of you. This is an area that is, of course, of significant interest, not just to you as regulators, but to me as an educator, to many of us as healthcare professionals, and at some point to all of us, actually, as patients. And so to begin with, what I'd like you to think about is the answer to this question. What keeps you awake at night? Not, did you do all of your Christmas shopping? Not, are you going to get to this meeting on time? But as human beings who at some point have accessed the healthcare system, who will access the healthcare system as we age, and who have relied on the healthcare system to take care of loved ones, what is it that you think and worry about with respect to the care you're going to receive? And as you reflect on that question, which is more than just an academic question or a flashy way to start a presentation, I hope one of the things that we consider, of course, is that the work that all of us do, whether we are healthcare professionals, regulators, educators, working in professional associations, whatever we do, is really focused on that thing that each of us as human beings is going to need at some point. I think this is a very important and useful way to start thinking a little bit about competency, because as you think of the answer to this question, I'm sure very few of you would think, well, what keeps me awake at night is that my respiratory therapist isn't going to be able to suction me appropriately if I need that. That my cardiologist isn't going to be able to interpret an ECG appropriately if I need that. My psychiatrist isn't going to be able to prescribe antidepressants appropriately if I need that. Because as human beings, when we think about our needs and the needs of our loved ones, the word that comes up most frequently in answer to this question is the word care. What we really want is for our healthcare professionals to care about the work they do, to care about us, and to care enough that they give us their best. Because at the end of the day, what are healthcare professionals? They are generally smart people who are nice and wanted to do something positive with their life. And if they care, we can generally expect that they're going to be able to figure out what it is that we need. Where most of us worry as patients about our healthcare needs is when we sense that our healthcare professionals are too busy, they're distracted, they're angry, they're bored, they're irritated with their boss or their institution. And so instead of caring, their cognitive and emotional energy is spent on something else. If we think about competency in this way, if you think about your work and I think about my work in this way, perhaps actually we start to think a little bit differently about what it is we're supposed to do. If we think about what the problem is that we're trying to solve, what is competency assessment? What's a regulator supposed to do? What are they supposed to care about? Generally, regulators are in the news, in the press, and in the public eye every time there is a high-profile case of a, quote, breach of duty of care. When something goes wrong, then all eyes turn to regulators to say, well, why didn't you stop this? How didn't you know? Shouldn't somebody have been vigilant to make sure that this wouldn't have happened? But when we have breaches of duty of care, how frequently are they about technical skills, technical issues associated with a profession and its practice? The term itself, duty of care, suggests that it's something more than the technical. And that's actually the starting point for what I hope will be an opportunity for you to reflect a little bit on the very important work that you do. What's the problem behind the problem? Competency is a word that we use all the time. Competency is something that you are going to be spending a lot of time discussing. You've already spent a lot of time at this meeting discussing things like standards, and standards and competencies are very clearly twinned. But the problem behind the problem, I would suggest, is much more complicated and interesting and important than the things that are captured in standards or competency statements or traditional assessments that all of us rely upon in order to safeguard the public. The problem behind the problem is much more rooted in what's happening with professionals and the whole concept of professionalism, not just in physiotherapy or in Ontario, but in all professions across the country and around the world. And it has to do with the whole shift in what it is to be a professional? As the last bullet on this slide suggests, in a world where some, if not many patients, actually know more about their health care than patients do, what does it mean to be a professional? As a pharmacist, there are many situations where I'm speaking to patients, educated, informed people who aren't pharmacists, like every single one of you in this room, who are perfectly capable of looking things up on the internet, and because they care, they have an interest, they have a vested interest in things, they will know much more about their medications than I do. You talk to a cardiologist, a surgeon, a nurse, a PT. When educated people have an investment in their healthcare, in a world of abundant information, they can and do know more about something than their patients do. Than their practitioners do. What does that mean in terms of what competency looks like? And so, if we think a little bit about what all of this means, there are two questions I'd like to have you keep in mind as we go through this presentation. First of all, do you believe that professionals are the ones that actually solve problems and make society better? And secondly, do you believe that regulation, as it is currently practiced, is the actual reason that most patients are generally satisfied and well taken care of? Because make no mistake about it, for all of the time and energy you will spend on discussing competency and standards and assessment, the reality is in every profession around the world, incompetent practitioners, as defined by their profession, account for about 1.5% of the entire membership. The vast, vast, vast majority of people who practice a profession, are nice, well-intentioned, caring, and do their job really well. And yet enormous apparatuses have been assembled to deal with 1.5% of a group where there may be some questions about what they are doing. But if you think more about this, let's think about a typical day in healthcare and the kinds of things that keep many of us who are going to be patients awake at night. These are actually situations that I have seen in my routine work as a pharmacist. So in my profession in pharmacy in Ontario, in order to call myself a pharmacist and to keep a Part A license, an active practitioner license, it means that I need to work in a patient-facing setting for a minimum of 4 hours a week to keep calling myself a pharmacist. So I do that. Even though I'm at the university full-time, I work for 4 hours a week, Tuesday nights at Mount Sinai Hospital. As I was mentioning to the group at the back, if you are sick on a Tuesday night and need any sort of pharmaceutical care, you may want to consider another hospital other than Mount Sinai. But these are things that I have seen over the last couple of months and years in just my 4 hours a week working in a large, complex healthcare organization. A nurse has been badgering a physician for a prescription for a patient. Finally, at 9 p.m., the prescription is written, and the nurse sends that prescription off to the pharmacy, which closed at 9 p.m. This happens all the time. Oh, no, we're closed. Yeah, but I just got the prescription now. Yeah, but we're closed, but I got the prescription now. There are mechanisms, of course, in order to get that prescription, but those mechanisms take time, result in delay, contribute further workload. Would any of us say that the pharmacist who says, we're closed, is incompetent? I don't think there's any competency standard I'm aware of in pharmacy or any other profession that says, no, like it's closed, the place is closed. That's the end of it. Yet if you were a patient and you needed that medication, if it was for pain, if it was for nausea, if it was for something that you are suffering with, and because of what's going on in this scenario, you're delayed in getting your medication, half an hour, 2 hours. If a nurse is now distracted trying to track down a medication through a night drug cabinet because they couldn't get it through this normal process, these are the things that we worry about, that my pain isn't going to be managed, that I'm going to be throwing up when I really don't want to throw up because it hurts. A physiotherapist is trying to assess a patient's mobility and joint status and needs an x-ray order to do so properly. He approaches a medical resident from the medical team and is informed that the patient in question isn't mine. The order is not written until the next day when the team rounds again. And so, again, because of the delay of a day, because, oh, that's not my job, it's not my responsibility, Yeah, but you just need to fill in this requisition. It's sort of a quirky policy we have here that physiotherapists can't order this independently. I'm not asking you to perform brain surgery here. Just sign a form. Well, it's not my patient. Just sign a form. I'm not extorting any money from the system. Like, I just need you to do something. Not my job. That worry of not my job. We close at 9. I've got to get home to my kids. I don't have time to care about you as a patient. This is just the job. These are all of the slippery, important, but real problems that patients experience. That I would respectfully submit. None of us, whether you're a regulator, an educator, a professional working in an association, have really quite understood. When we look at the competency literature, it is so overwhelmingly dominated by questions around reliability and validity of assessments, definition of standards, the kinds of things that we spend so much time thinking about that won't remotely influence these two patients in this case, and perhaps don't really address the core issue of what it means to be a professional in 2016. What is competency? Well, if you look it up in a dictionary, it's of no help to you. The generally accepted definition of competency is the quality of being adequately or well qualified physically or intellectually. That's of no help to any of us. But the word competency is frequently used as the basis for evaluating success, defining readiness for practice in a variety of fields. And we know that it's a word that has very different meanings to different people in different contexts. To the patient who is nauseous and desperate for an antiemetic medication, that pharmacist who left at 9 o'clock, even if their union contract said, we close at 9 o'clock, even if that pharmacist has children to contend with, or they got a life of their own, that pharmacist who left at 9 o'clock is not competent. Because here I am thrown up in a bucket when they could have done something. If we ask patients, and weirdly, we so rarely do ask patients, what is it that you think makes for a competent physical therapist, or nurse, or social worker? There are 3 terms that come up over and over and over again. And those terms are accessibility, affability, and acknowledgement. What patients think competence means is that there's a healthcare professional there when I need it, when I need him. So I don't care that it's 9 o'clock. My nausea doesn't follow a clock. I need somebody there who can help me. They want somebody who is nice. Somebody who actually will not just say, yeah, there's your antiemetic, go. But somebody who will go, how are you doing? Everything okay? Oh my goodness, it must be so hard for you to experience all of this. And somebody who actually listens to their concerns, who doesn't just dismiss them, who doesn't treat them as part of an algorithm, who will actually look you in the eye rather than just be writing things on a piece of paper. Conspicuously absent from this list is the notion that for patients, professionals actually know what they're doing. Esoteric discussions around inter-rater reliability of assessments, whether you are using a standardized OSCE for assessment versus a multiple choice assessment, they don't really care about that. And in fact, when you drill down on this, patients are extraordinarily forgiving of technical errors because they realize that healthcare professionals are human beings, so long as their healthcare professional treats them like a human being. You will know this if you do spend 10 minutes with your discipline and complaints records. Why do people complain about physical therapists or any healthcare professional? It's because of these issues. A simple mistake, an honest error that's committed by a caring healthcare professional is almost never going to result in a public complaint. But a small error with few consequences that's managed in a very impersonal, brusque, mean, ignoring kind of a way. That's what drives people crazy and drives them to complain. Competency then for patients isn't necessarily about a technical skill. It's about interpersonal savvy. As we know, and virtually across all professions, the vast majority of professionals do their job well. They actually are kind, caring, committed, engaged. They will actually go, I really need to pick my kids up at daycare, but okay, I've just got to do this. And they'll do this to the best of their ability in the circumstances. And if they can't, they'll apologize for it. They'll make other arrangements. They'll actually try. Trying is such an important aspect of what patients generally believe competency looks like. As you discuss and debate your profession's competency assessment schemes, how do you actually measure, evaluate, or encourage practitioners to simply try their best? And perhaps if you flip that around, to what extent are the things that you are currently doing around competency assessment actually deflating practitioners? Maybe leading them to think, fine, just tell me what you want me to do and I'll jump through the hoop. But if you don't tell me what to do, I'm not going to do it, because 9 o'clock, I get to leave. Let's look at competency then from another perspective, from the perspective of some of you in the room who are physiotherapists, from somebody like me who is a very part-time pharmacist. What is competency from that perspective? Competency is a hoop that needs to be jumped through, and a hoop that's increasingly difficult to jump through, because in most workplaces, in most educational settings, and in many regulatory contexts, competency has the flavor of gotcha. The idea that someone's just sort of circling around and we're not, you need to know what competency is. But then when something happens, we gotcha. For most practitioners, there is a complete understanding that mistakes happen. It's impossible not to make a mistake. In an extraordinarily detailed-oriented profession like pharmacy, where if you're a pharmacist working in a drugstore, for example, you might be responsible for dispensing 400 prescriptions in a day. You think counting in multiples of 5 all day long, seeing 400 tiny vials with tiny red, blue, white pills with tiny writing on labels, you think you're not going to make a mistake? No, you're going to make a mistake. That's what human beings are going to do in situations like that. Does making a mistake equal lack of competence? If it did, every single professional in the world would be incompetent, because there but for the grace of God go I. The only thing that is different is, did someone catch the mistake? Did you manage the mistake effectively? Did you apologize? Did you just happen to be in the wrong place at the wrong time? This is particularly important in increasingly interprofessional contexts, because as any of you who are physiotherapists know, as increasingly we rely upon the work of other professionals for our work. So a family physician may rely on my work as a pharmacist doing a medication history to make a decision. A physiotherapist may rely on a nurse's assessment in guiding a treatment decision. But as we have to start to rely on other people, if we're the people that make a mistake because we relied on someone else's mistake, how are we supposed to feel about our competence? Defining competence as error is an extraordinarily difficult and challenging issue. Well, what's your job then as regulators? If you look through the regulatory literature, there are certain words that come up over and over again that regulators are meant to be concerned about. Safety of the public, we protect the public. Transparency for members, accountability, consistency. But a word that we don't see, that is a lived reality for most members or practitioners, is that competency has evolved within the regulatory context to have an adversarial quality to it. You're the regulator, I have to jump through certain hoops to prove to you that I'm competent. You want to come and visit my practice? Sure, you can watch me work. You want to review charts? Sure. Just tell me what you want me to be, and I will be that person. We might like to think, from a regulatory perspective, that a 4-hour visit with a practitioner watching them in action is an actual reflection of what they do on a day-to-day basis. But we've all been children, and we all know that when mommy or daddy is watching you, you behave very differently than when no one is watching you. The adversarial nature, that notion that you prove to us that you are competent, establishes a perhaps peculiar relationship between members and a regulator. But more importantly, we need to question, does it actually work? Does a snapshot in time of what a practitioner is doing actually reflect whether they care, whether they try, whether they stay until 9:01 to dispense a prescription, or whether or not they will actually sign a requisition for an x-ray even though the patient isn't theirs? I've had the great good fortune of being a professor for about 25 years, and one of the things that I see, and many of you who are involved in education will also see, is how rapidly the educator's role has changed over the last about 15 years for those involved in health professions education. I got into my job because, honestly, I actually didn't like the idea of testing. I was an extraordinarily mediocre student. I didn't respond well to sort of the multiple choice test conditions, but I actually really liked the nurturing, developmental, be the best that you can be quality that I thought education was all about. And for the first 10 years of my career at the university, working with pharmacy students, that's what it was about. It was about socializing students into a profession. It began with the assumption that we had 6,000 people applying for 120 places in pharmacy school. So the 120 of you that got in, you're pretty smart, you're pretty nice, you'll figure out the details. My job is to help you to figure out what it means to be a professional, how to sort out why you should stay until 9:01 to dispense a prescription, how you should care about patients, those sort of developmental things. In pharmacy, physical therapy, medicine, nursing, every profession, there has been such a radical shift in what teachers do now. It's all focused on competency assessments. Those of you that are involved as preceptors for young physiotherapy students, you spend a lot more time filling out forms and doing checklists and doing competency matching documents, rather than actually discussing what it means to be a professional. Driven perhaps by regulatory demands, general social changes, we are spending less and less time socializing people into what it means to be a professional than filling up all of these forms. Some of you in the room will actually be employers. You're responsible not just for running organizations, but ensuring that customers are well pleased, clients are well served. From an employer's perspective, what is competency all about? Interestingly, it's all about a very commoditized view of professional work. Increasingly, especially among large employers, and there's some really interesting work in this from the National Health Service in the UK, which is the largest employer in the world, not just an employer of healthcare professionals, but the largest single employer in the world. As organizations get larger and more impersonal, there is a sense that the actual work that professionals do is interchangeable. And that's something we actually need to think about. Why do we have professionals in society? Those of you that are physical therapists, I like being called a professional. Being a professional seems kind of neat. Like, oh, you're a professional. We use it as an adjective to describe, that person behaved in a professional way. So that means that they're very smart, they're cool under pressure, but we actually have professionals in a society for a very important reason. Because when we're dealing with human beings, many problems defy simple procedural solutions. If a computer could figure things out, you wouldn't need a professional. If every problem was simply a matter of checking an algorithm to laboratory data, you could have technicians solving problems. And this is in no way dismissive of technicians. Technicians are incredibly important in a system because, of course, they apply technical procedures. But if you are a professional of any description, you will know most of your work deals with situations where things are gray, where there isn't a policy, there isn't an algorithm, there isn't a standard that you can match against, that you actually have to exercise judgment. And as organizations get larger, there is a push away from allowing professionals to be people who exercise wisdom and judgment, and instead encourages them or forces them to simply comply to a series of pre-digested rules. And when we start to work in cultures like that, what happens? 9 o'clock, my shift's done. Not my patient, somebody else needs to do that. If we work in organizations that bias away from professionalism, is it any wonder then that when we need someone to be professional, they don't know how to anymore? So where does this leave all of us? It leaves us in the sticky situation of having a social responsibility to ensure competence of practitioners when we don't even know what competence necessarily is, where all of us actually have very different ideas of what competence is, and even as an individual, your definition of competence might change based on the circumstance you're in. In the cool, dispassionate comfort of a boardroom, where you aren't a patient, where you aren't a person requiring professional intervention and care, it might be very easy to reduce competence to a series of statements on a page, a checklist, something that looks very technical. But if you're that patient who is extraordinarily nauseous and wants something now, not 2 hours from now, competence is going to look extraordinarily different to you. The other thing we need to, I think, very seriously consider is regulators, educators. We've been in this competency assessment game for a long time. Has it actually mattered? Have we actually ever stopped a problem because somehow our current systems have actually caught somebody who isn't competent before they've inflicted harm on somebody? And if we flip it around, what about the other 98.5% of people? Have our systems actually demoralized, discouraged, and deprofessionalized them? So that now they think we're just widgets in a system. Fine, tell me what loop you want me to jump through and I'll do it. But don't expect me to stay until 9:01, because now I'm just a hoop jumper. The literature on competency has been evolving significantly and has led us to a couple of conclusions about what our current systems have actually accomplished. The first and perhaps most compelling argument that's been seen across many professions and many jurisdictions has to do with one of the most common forms of competency assessment. The notion that compulsory continuing education somehow guarantees or promotes lifelong maintenance of competency. In many professions for many years, there's the idea that if you spend 20 hours each year in continuous learning, continuous education, somehow that's going to ensure your competence. And so for generations, many physiotherapists, pharmacists, doctors would traipse off to hotels, listen to someone talk for an hour one evening, enjoy a floppy chicken dinner and talk to someone, and then go home. And what the literature has been very clear on is that attendance at compulsory continuing education and completion of continuing education does not predict competency. It's something, if it's a hoop that we're required to jump through, that's how we'll treat it. And so competency assessment and competency systems built solely or predominantly on continuing education might look good from the public's perspective. Oh yeah, we force all family doctors to study for 25 hours a year to keep their competency. As all of us know, there's studying, and then there's studying. The other thing that is emerging across various professions is the notion that there is something called competency drift. This is, I think, a very important concept that all of us, regardless of what field we're in, need to consider. And competency drift begins with the notion that virtually all healthcare professionals, maybe even more than that 98.5%, are nice, well-intentioned, smart people who want to do a good job. That's actually a pretty reasonable intention. I don't think that there's probably anybody who became a physiotherapist out of mean or nefarious intentions. I'm gonna really work hard, I'm going to get into physiotherapy, I'm gonna be a physiotherapist, I'm gonna wreak havoc like Dr. Evil around the world. Nobody does that. Most people are healthcare professionals because they're nice, smart people. But over 10, 20, 40 years, what happens? We drift. All of us know about drift in other areas of life. The example I always like to give about this was my technological drift. About 15 years ago, for example, I missed out entirely on MP3 players. For whatever reason, I just didn't listen to music. I had these little devices. I saw all the kids walking around with them, and people didn't seem to have CDs anymore. And there was this thing called the Apple iTunes Store. I heard of it, but I just missed it for a variety of different reasons. And if a couple of you are nodding, and if you get to a certain age, you will know that if you miss a technology, it's really hard to ever catch up. Because if you miss MP3 players, you kind of miss the iTunes Store. And if you miss the iTunes Store, you miss this whole downloading phenomenon. And if you miss downloading, you miss how to download illegally. And if you miss that, you just miss one after another after another. This is in some ways a metaphor for how competency drift occurs. Every field evolves. But when you miss one step of something, all of a sudden everybody else is racing ahead of you, and you're a little bit shy or hesitant to admit, I missed this step. And you say, mañana, I'll deal with that tomorrow. But of course tomorrow, the next step has occurred, and you become further and further and further distanced. Competency drift suggests that there is nothing malicious, there is nothing mean, there is nothing nefarious about how people drift from competence. There is nothing mean or malicious about me missing MP3 players. I just did. It's just that simple. I just did. But the problem comes when we start to label it as incompetency. Because all of a sudden, my missing MP3 players has a weight to it. It's not, oops, I just missed this. It's, I'm incompetent. And if I'm incompetent, am I going to ask somebody for help? Am I going to acknowledge that I missed MP3 players? Am I going to actually reach out to my regulatory body and say, can somebody help me with this? The label that we use carries an extraordinary weight, especially with practitioners. And if we frame things around competency, one of the knock-on effects that we need to acknowledge, of course, is that it's going to resonate with them in a way that perhaps we didn't intend. We might use the word competency assessment in a well-intentioned way, but no healthcare professional, no one who is a nice, smart, well-intentioned person would ever want that label applied to them. And if they don't want that label applied to them, how on earth are they ever going to reach out to you? And who else do they have to reach out to other than their regulatory body? In the March meeting, one of the things that we're going to review is a report that I and some colleagues have been working on for your college, looking at a variety of competency assessment models. This is meant to just be a sneak peek of some of the different models that are out there. This has been a wild and woolly exploration of a lot of different things educators, regulators, employers, lots of different professional associations have been doing in order to address this issue of competence. And as you just scan through this list right now, more details will be provided at the March meeting. One of the things that you will note is that overwhelmingly, competency assessment, as you would imagine, has the flavor of testing, evaluation, hoop jumping, and an adversarial kind of relationship. This historically perhaps makes sense because the only time governments, the public, the general society seems to have interest in regulatory bodies is when stuff goes wrong. So when there is a high-profile case of error, all of a sudden, well, why wasn't the college involved in that? One of the most interesting things to consider is in Ontario in particular, if you track back the reason why competency became such an interesting topic in Ontario, and why, as the literature review we've been working on suggests, Ontario is hands down the world leader in competency assessment, not just College of Physiotherapists. Every regulatory body in Ontario, we're world leaders in this whole area of competency assessment. You can actually track back the competency assessment movement in Ontario to a very high profile, actually two very high profile cases in the early 1990s that some of you may remember. In the early 1990s, your colleagues at CPSO, the College of Physicians and Surgeons of Ontario, dealt with some very embarrassing cases of sexual misconduct for two of their members. And CPSO at that time wasn't particularly harsh on the members. They were actually convicted through the disciplinary process of sexual misconduct. But when the media got hold of what the penalties were for those sexual misconducts, there were like, I think, 6-week suspensions, and you had to write an apology note. And as you can imagine, the press, the public, and the government went ballistic over that, because it had the flavor of the profession is just circling the wagons around its own, they're protecting their own, this is ridiculous, we can't trust you to be self-governing professions. And so, starting about 1993, some of you may remember back then too, we had an NDP government elected, and one of the things that the NDP government did was introduce sweeping changes to the Regulated Health Professions Act that required all professions to institute transparent quality assurance programs to ensure competency of their members. Let's think about that for a second. Sexual misconduct, competency of members. How did the message of you need to deal with sexual misconduct seriously suddenly morph into elaborate, extensive, expensive, and invasive competency assessment for all members? 2 physicians, roughly 48,000 professionals covered by the RHPA at that time. Competency, the trajectory of competency assessment in Ontario was very much framed around that high-profile incident, a press that was looking for blood, and a government desperate to be seen to be doing something. The reality is no competency assessment program is ever going to root out the kind of sexual misconduct that led to this. Yet, the legacy of that experience more than 20 years ago are elaborate competency assessment systems that once again drag in the 99.99999% of practitioners who were never and would never think of being involved in that kind of sexual misconduct, and the 98.5% of people who aren't incompetent in any stretch of the imagination. As you can tell from this perspective, there's a little bit of news, but a whole lot of editorial in what I've said over the last little while. One of the things that I would suggest, looking at the competency assessment literature and thinking about its evolution in Ontario, is that there is a lot missing in what we all do in terms of competence. What are the missing bits? Addressing these kinds of things. It's not my job. Well, if I answer this question, everybody is going to come to me and ask me, so I'm just not going to answer that question. If I stay late this time, the nurses will never learn that we close at 9 p.m. And it's more important that the nurses learn a lesson than the patient gets their antiemetic drug. This is just a job. Like, no, I start at 9, I go home at 5, it's just a job. Good enough is good enough, right? I'm just doing what I'm told. Society desperately needs individuals who are nice, smart, well-intentioned, people who understand that it's not possible to have an algorithm to actually make decisions, that you need people who actually can exercise wisdom and judgment. And how do you exercise wisdom and judgment best? When you actually care. When you care about your patient, when you care about your job, when you care about your profession. You need to actually have a certain amount of investment in what you do in order to be wise. And there are so many circumstances, particularly in healthcare, where what we're looking for is frankly not competence, but wisdom and compassion and caring. And if our competency assessment systems, which have that adversarial, testing, judgmental, evaluative component to it, actually start to interfere with an internal sense of professionalism, what good have we actually done? And so, as we sort of wind down with this presentation, what if we were to define competency not as that weird dictionary definition of the quality of being adequately or well qualified intellectually or physically, but instead thought of competency as smart, nice, well-intentioned people demonstrating that they're firing on all pistons and giving it their all, trying their best? How would things be different? There is increasing interest in this line of thinking, and it's crystallized in the notion of engagement. Engagement is a psychological state of firing on all pistons. It is that moment where you're really caring and trying about what you do. I'm not naive enough to think that for 8 hours a day, 5 days a week, 50 weeks a year, all of us can be firing on all pistons all the time. But when it counts and when it matters, are we actually allowing professionals, encouraging them, incentivizing them, helping them to fire on all pistons when it counts? There's a wonderful quote here about what life in organizations might be really about. Within a regimented, legalistic, and bureaucratized system, we cannot become attached to higher aims and submit to a rule if we see nothing above us to which we belong. This quote from ED in '97 was not some executive director of a healthcare association in 1997. It's actually the sociologist Emile Durkheim in 1897 talking about the life of factory workers. People who worked on assembly lines, people who worked in highly mechanized, routinized, regimented, algorithm-driven organizations, who would shrug their shoulders and say, it's just a job, I'm following the rules, I'm doing what you told me to, I'm jumping through the hoop that you set for me. He coined the term anomy, which is a condition in which society provides little guidance to individuals, which results in people simply not caring about their environment, their colleagues, the work that they're actually doing. The pharmacist who leaves at 9 o'clock, knowing full well the production that it's going to result for that nurse to find the medication. The medical resident who says, not my patient, knowing that the physiotherapist is now going to be condemned to be roaming around. Can someone sign this down? You know what, I've tried 10 times, no one's going to sign this. If no one else cares, why should I care? That sense of anomy, of drifting, of just lack of connection to anything, that is the real competency problem, I would suggest, we really need to consider. I would love if at this point in the presentation, this slide presented all of the answers. Because of course there isn't. The literature scan that we've been working on, that will be presented at the March meeting, presents some really interesting insights into how most professions, especially in health, have tried to struggle with this. I'm extraordinarily sympathetic in some ways to why competency assessment has evolved the way it has. Because when you have the Toronto Star breathing down your neck, a government, a patient complaining, you have to be seen to be doing something. But the inadvertent problem when the doing something is not only not helping the real thing that you're trying to solve, but actually having a boomerang effect and causing other problems is something we all need to consider. 2 high-profile, dreadful cases of sexual misconduct at the College of Physicians and Surgeons of Ontario in 1992, an incredible apparatus around competency assessment in 2015 that doesn't solve this problem, and arguably has created other quiet problems around disengagement, anomy, and competency drift. So as you think about your job as regulators, one of the things I would hope you're able to keep front and center is the notion of why you are here. Why do we have a College of Physiotherapists? Why do we have physical therapists in the first place? Because we need professionals. What do we need professionals to do? Not to pass tests, not to memorize textbooks, not to be walking encyclopedias of biomechanical knowledge. We need professionals to think, to observe, to connect, to try, to understand, and maybe most importantly, to fire on all pistons. Because they are nice, smart, well-intentioned people. And if our workplaces, our educators, and our regulatory bodies have conveyed or enforced a message that you are just a widget, you just jump through this hoop, everything is going to be okay, don't think too much about things, what good have actually any of us done? In the remaining slides, there's some information about something called engagement, or something that the psychologist Mikhail Csikszentmihalyi has coined, the term flow. And flow is that psychological state where we do fire on all pistons. What Csikszentmihalyi points out is that what antagonizes flow, it's when you're feeling bureaucratized, when you feel you need to jump through a hoop because somebody wants you to do some make-work project. You know, something like Oh, I have to submit my learning portfolio to my regulatory body. What did I do this year? Yeah. Those sorts of make work kind of projects do not only perhaps very little to support competency, they probably do quite a lot to antagonize flow. A couple of final comments before we have a little bit of a discussion. Again, this has been a lot of editorial with a little bit of news. You've had a lot of my perspective with a little bit of evidence thrown in there. And so I would caution you that to a hammer, everything looks like a nail. To somebody who has a perspective that competency assessment, perhaps there's been some overreach amongst regulators, educators, all of us, in terms of what it can legitimately do, you're getting a lot of my perspective on that. And so to a hammer, everything looks like a nail. This is a complicated issue that defies a simplistic and bureaucratized solution. And we need to recognize that there may not be one right answer, but perhaps some least worst alternatives we need to consider. Interestingly, that last bullet is exactly the definition of what it means to be a professional. If there was always a right answer to a clinical problem, you'd never need a professional. A patient could look it up on the internet, a technician could implement it by looking it up on an algorithm. The reason we have professionals is because there aren't right answers all the time. We need judgment, wisdom, compassion, and caring to figure out what our least worst alternatives are instead. So thank you very much for this opportunity to share some of my thoughts on this. If you're interested in some further references or reading on this, here are some. There will be, at the March meeting, another additional reading for you, and that's the competency assessment scanning review that we've been working on, that I hope in the context of this presentation may give you some food for thought.